Good evening, I'm Jerry-Ann Higgins, and I'd like to welcome you to the UVM Health Network Health Source presentation of Genetics, Breast Cancer, and You. Health Source is a free educational program that offers classes on a wide variety of health and well-being topics, led by our UVM Health Network experts. Tonight, we're joined by experts from Champlain Valley Physicians Hospital in Plattsburgh, New York, and the University of Vermont Medical Center in Burlington, Vermont. I'd like to now introduce you to our two experts, Dr. Manal El Daouk of CVPH and genetic counselor Wendy McKinnon of UVM Medical Center. Dr. Manal El Daouk comes to us from the Department of Obstetrics and Gynecology at Champlain Valley Physicians Hospital in Plattsburgh. Dr. El Daouk has published multiple articles with a focus in obstetrics and gynecology and has a range of clinical research experience. She also holds multiple clinical awards. She is a member of the Lebanese Order of Physicians organization and has also been an ongoing active member of CVPH's Commission on Cancer Committee that is dedicated to improving survival and quality of life for cancer patients through a standard setting, which promotes cancer prevention, research, education, and monitoring of comprehensive quality care. As of this year, she is now a member of CVPH's Institutional Review Board. This committee protects human research subjects by reviewing research studies. In her limited spare time, she enjoys playing piano, teaching medical students, and biking outdoors. Also joining us is Wendy McKinnon. Wendy is a certified genetic counselor who has specialized in cancer genetic counseling for over 20 years in the Familial Cancer Program of the UVM Medical Center. The Familial Cancer Program is a robust cancer risk assessment program that offers genetic counseling and testing to individuals and families concerned about inherited cancer risk. Wendy sees several hundred cancer genetics patients a year, coordinates the institution's universal screening program for Lynch syndrome, participates in multiple tumor boards and conferences, and takes part in ongoing research projects, both at the University of Vermont, as well as collaboratively with other institutions. I'd like to now invite Dr. El Daouk to officially begin our presentation of Genetics, Breast Cancer, and You. Welcome.
Thank you very much. Thank you very much for joining us today to talk about genetics and breast cancer. So breast cancer is considered as the most diagnosed cancer in women in the United States. And the woman's lifetime risk of developing breast cancer is approximately 12%. And that makes 1 in 8 women develop breast cancer. And it is considered as the second leading cause of cancer death. The 5-year survival rate for female with invasive breast cancer had significantly improved when compared to mid-70s. Nowadays, it is 90% survival rate. And this is due to multiple factors. One of them is improved regular screening and the assessment risk, as well as the treatment options that we have nowadays. So let's talk a little bit about the goal of screening. So the goal of screening is to definitely, like when we go for screening for any kind of cancers, is to early diagnose any cancer, and thus we will have a better outcome. So it will definitely improve survival and improve health outcome, and it will give us a better quality of life by avoiding more intensive treatment. So the screening recommendation, it can be a little bit confusing. If you look at this table, there's multiple experts who came up with many guidelines. Basically, all of them kind of depend on the cost effectiveness and risk and benefit. And at the end, it's a shared decision between you and your doctor, is which modality you want to go and how often you're going to do the mammogram and when you're going to start. So for clinical breast examination, basically, we start doing them at the age 25 and then annually after the age of 40. For the mammogram, I usually like to start them at the age of 40, but there's some recommendations say that you can start them between 45 and 50, and that could be every year or every 2 years. And when to stop is a lot of you asks, I'm doing mammogram every year, when I'm supposed to stop. So usually the mammogram, most of the recommendations say you can continue doing mammogram up to the age of 74. After that, it all depends on your overall health status. You're healthy enough, your life expectancy is more than 10 years, and you would like to continue doing the mammograms, definitely you can go for that. And we'll be talking right now a little bit about self-breast examination. A lot of people kind of, inquire about how to do that and when to do it. I just want to give a little bit of note. The breast examination, self-breast examination, is recommended in high-risk women. Usually, we do it after the period, after you finish your cycle, about 2 or 3 days. And it's very important to check your armpit to look for any lumps or any kind of masses. And using your finger pads, we do all systematic examination of your breast, up and down, wedges and circles. And it's very important to look at the mirror to make sure that there's no skin changes or dimpling of the skin. And very important to look at the nipples, warning sign, nipple deformation or inversion, that's our warning sign. Nipple discharge as well, something you look at the end of the day, taking out your bra and you find stain on it, that is considered abnormal and you have to tell your doctor. So most of us, as we said, we are average risk. That means lifetime of developing breast cancer is about 12%. Is this recommended, which is the self-breast exam? Actually, kind of recently, they mentioned that it is not recommended because that might increase an anxiety level and you might find something and that will increase the risk of having more imaging and probably biopsies. So that might increase risk of false positive. However, they have recommended breast self-awareness in average risk women. That means you know yourself. So if there's anything have changed, then you can come and tell your doctor, like you have noticed masses, you have noticed skin changes and everything that we have mentioned earlier to look for. So second, we're going to talk about the risk factors. What are the risk factors of developing breast cancer? One of them is lifestyle. It's very important. We always say, exercise definitely 4 hours per week, maintain a healthy weight, limit alcohol intake, any of these because might increase risk of breast cancer. Menstruation, people who had their period before the age of 12 or went for menopause late after the age of 55, those who had no children or they never breast their babies or their first child after the age of 35, all of them had been kind of, expose you to more lifetime risk of having kind of estrogen, and that might increase risk of breast cancer. Other things is hormone replacement therapy. The main thing as well, some progesterone might kind of cause, it's found that might increase risk of breast cancer, but mainly the density, the hormone replacement therapy increase your breast density, which make it a little bit harder for the mammogram to pick up early. So at family history and genetics, you have a family or a relative member who had ovarian cancer or breast cancer at a young age, or already there's somebody in the family who had been tested positive for a genetic mutation that can predispose you to have breast cancer. Also, other risk factor is just being a woman or getting older, being exposed to radiation or some chemicals, and or you have some breast biopsy in the past that might increase risk of breast cancer. All of these could be a risk factor. Today, our talk is going to be emphasizing more on genetics and family history. To go through history a little bit, I'm going to talk about genes. What are the genes? So this is Sir Gregor Mendel. He's considered the father of modern genetics. In the 1800s, he proposed the Mendelian inheritance. Basically, he was a farmer who worked with plants. Mainly, he conducted hybridization experiments with the pea plant, and he found an observable evidence of how parents transmit genes to their offspring. That's followed by Sir William Batson, who is an English biologist, and he was the first to use the term genetics to describe the study of heredity. So what are the genes and what is their function? So you will think right now I'm going to do a little bit summary on biology. So those who know about it, I'm sorry that bear with me a little bit. So our body is made up of billions of cells, and is in the center of each cell lies a chromosome. And one strand of this chromosome, the chromosome is made of very long strands of DNA, and segment of this DNA is called a gene. So if we think about the DNA and the gene, like DNA is a book of recipe and the gene is a recipe. The gene is responsible to tell the cell to produce protein in order to function. So basically the gene is the one who is going to decide our hair color, our eye colors. It's gonna decide the cell how long it's gonna live, when the cell is gonna die. So we end up by having 23 pair of chromosomes. One copy come from our mother and one copy come from our father. And the cell will divide and divide and divide until we end up by the most beautiful outcome you can imagine. So every gene, as we said, we have like in our body, there's about 20,000 of genes, and every gene does have a job. And one of the genes that I'm going to be emphasizing mainly today that we're going to be studying like on breast cancer risk is called tumor suppressive gene. The main function of this gene is to prevent cancer by controlling the cell growth. So what will happen if there's a mutation or like problem in this gene, the tumor suppressive gene? That will lead to a faulty cell growth. So to explain it a little bit, this is a normal gene over here, and this is a mutated gene. The normal gene is going to give us the good DNA with the appropriate recipe book and appropriate recipes, which is the genes. And the mutated gene is going to give us the failed recipe. We will end up by the normal gene is going to give us the good outcome, and the mutated gene is going to give us the bad outcome. And if we describe this on real life, the normal gene is going to give us normal cell, and the mutated gene is going to give us cancer. So what causes that? Why did genes get mutated? So there are two main reasons that this might happen. One of them is hereditary. So that's mean we inherit a mutated gene from our parents to us. So sporadic, the other one is that gene mutation happen over time due to natural aging process or due to exposure to chemicals. So if you remember, we have talked about we get one copy from our mother and one copy from our father. Let's talk about, we're talking about still about tumor suppressive gene. We usually in sporadic cancers, the baby is born with two normal copies of tumor suppressive gene. It takes some time due to exposure, as I said, to chemical radiation, one copy gets destroyed. However, the person will not develop cancer because the other tumor suppressive gene is still working. After a long time, the other copy gets mutated, and thus there will be no functioning tumor suppressive gene, and thus cancer can happen. And in this situation, in the sporadic cases, cancer happen at an old age. As for the hereditary, the baby is already born with one mutated copy. One copy is not functioning. There's another copy that is still working well, so there's no cancer in here. It doesn't take too long where the other copy gets mutated, and thus cancer will develop. And in the hereditary cases, usually cancer develop at a young age. And a lot of people will think, oh my God, my mother had breast cancer, my sister had breast cancer. Does this mean that this is going to be hereditary, something going on? It's only 5 to 10% of all breast cancer cases are due to hereditary causes. So, when you, there's some red flags. When you're going to know that, oh, why I'm going to have genetic mutation, what are my risks, and when should be thinking about that I might be having a genetic mutation. There is some family history that may raise suspicious. One of them is that you have a relative with breast cancer diagnosed at a young age. The other one is if you have a family member with both have breast and ovarian cancer. If you have a family member with triple negative breast cancer, maybe if this is younger than the age of 60. If you have family member with, in addition to the breast cancer, there's the prostate cancer, the melanoma. I'm going to talk why these can be considered as genetically transmitted. Pancreatic, stomach, uterine, thyroid, colon, or sarcoma. And also, if you have a family member with bilateral breast or breast cancer, cancer in both breasts, or if you came from an Ashkenazi Jewish heritage, or if you have a rare cancer that runs in your family, like a man who has breast cancer in your family. Or there is, somebody in your family had been, as you said, tested positive for a gene mutation, then that might put you at risk of that yourself might have a genetic mutation. So how to assess the risk? Usually when you go to your doctor, there's certain risk assessment tool that we usually follow. I'm not going to go through into the details about them, but this is usually kind of we calculate your lifetime risk of developing breast cancer and what's the risk of that you might be having genetic mutation. And there's a guidelines that comes from expert group on when to test. This is a very busy table, but this is usually when you go to your genetic counselor or your doctor, that's kind of you go through this one to decide whether you need or qualify for genetic testing. So let's say here you have a family history with breast cancer, yourself is healthy. Who should be tested? It's very important to ask the affected individual in the family who had an early onset breast cancer or ovarian cancer or BRCA associated cancers like pancreatic cancer, melanoma, or early onset prostate cancer. That person should be tested. If still alive, that would be the best thing to do. So we were talking about tumor suppressive gene. A lot of you have heard about BRCA1 and BRCA2. So what are they? BRCA1, every one of us do have this gene, the BRCA1 and BRCA2 genes. The function of this cell is, again, to repair cell damage and keep breast and ovaries and other cells growing normally. That means it will keep everything under control. In real life, it will make the normal cells divide and know when to stop, so cancer will not develop. And what happens when there's a mutation in this gene, everything is going to be out of control and will be increased risk of breast, ovarian, and other cancers. The cancer is going to divide and divide and divide, and then we're going to end up by having cancer. It is the most inherited cases of breast cancer, genetic mutation. And the incidence, it is rare, but it's about 1 in 400 to 800. However, it's 1 in 40 in Ashkenazi Jewish heritage. It increases the risk of breast cancer up to 80%. And ovarian cancer up to 60%, and as well, you will have like increased risk of male breast cancer, pancreatic cancer, and prostate cancer. So when women have a BRCA mutation or both, they tend to have breast cancer, as we said, at a younger age. As well, they tend to have cancer in both breasts or bilateral breast. And the men who carry the BRCA gene mutation are at risk of developing breast cancer with an 8% by the time lifetime risk of developing breast cancer by the time they're 80 years old, which is 80 times greater than average. Also, it will increase risk of prostate, skin, and digestive tract cancer. So the mode of inheritance of this gene is autosomal dominant. That means if one of your parents, whether a mother or a father, affected with this gene mutation, there is a chance about 50% that the kids are going to be affected. So it doesn't matter if your mother had carrying this gene or your father, if you have a family history of paternal breast cancer, that there might be, like if your father carries this gene mutation, it will be transmitted to 50% of the kids. So you know that you have, or a woman know that she have an abnormal gene that causes breast cancer. There are steps that we can take. Stay healthy, make sure that you maintain a normal weight, be active, and do not drink alcohol. These are things that from our aspect we can do. So there's other risk reduction options, such as more frequent screening. We said before, there's the mammogram we start at the age of 40 every year or every 2 years. In these women who do carry this gene mutation, we encourage breast self-awareness starting at the age of 18. Clinical breast examination, that means your doctor is going to do an exam every 6 to 12 months starting at the age of 25, and annual MRI with contrast at the age of 25 to 29. After the age 30, we add on the diagnostic mammogram, alternating with the MRI every 6 months. And when to stop, again, is such your decision making that you are going to take with your doctor. After the age of 75, you want to continue, you're in good health, definitely you can do that. And for men who carry this gene mutation, we encourage men to do breast self-exam and train them and educate them starting at the age of 35. Clinical breast exam, that the man go to his doctor and do the breast exam for him every year, starting at the age of 35. And then annual mammogram, especially in men who have like slightly enlarged breasts, usually at starting at the age of 50, or 10 years earlier than the earliest known male breast cancer in the family. And prostate cancer, because they are at increased risk of developing prostate cancer, we usually start screening at the age of 40 in men who carry this gene mutation. So the hormonal therapy medicine, there's kind of two groups that we can use. There's research still ongoing. It's mainly used for people who had high risk due to family history or prior biopsies. One of them is selective estrogen receptor modulator. They act against anti-estrogen in the breast. Tamoxifen can be used in pre and postmenopausal. Raloxifene, which is a medication probably most of you are aware of, that we use for osteoporosis treatment, and we use it in postmenopausal women, in addition to aromatase inhibitors as well. And most importantly, the protective surgery. One of them is removing breast, like healthy breast or bilateral mastectomy. That will reduce the woman's risk of developing breast cancer by as much as 97%. And removing the ovaries, healthy ovaries and fallopian tube before the onset of menopause will reduce the woman's risk of developing breast cancer by about 50%. And I'm sure most of you know Angelina Jolie. In 2013, she was diagnosed with BRCA 1 and 2, and she came up publicly, talk about her gene mutation and the decision she took, which required a lot of courage. She had both of her breasts removed because of that, and she came up with the quote, "My mother fought cancer for almost a decade and died at the age of 56. Actually, I also carry the faulty BRCA1 gene with an 87% chance of developing breast cancer and 50% chance of ovarian cancer. Since I did the surgery, the chance dropped from 87 to under 5%. I can tell my children that they don't need to fear losing me because of breast cancer." So for years, we know about BRCA1 and 2. However, recently we find out there's other genes that can predispose women to have breast cancer. There are many newly diagnosed with, they're kind of categorized into groups. The high risk group usually carry lifetime risk of breast cancer, more than 50%. The moderate group, usually lifetime risk of breast cancer between 25 and 50. So for the high risk and the moderate group, we both are called actionable. That means there's something we do for them to prevent breast cancer, more surveillance and the surgical options we can offer them. For the moderate group, we can offer them more surveillance. And for the newer group, they're called non-actionable. That means the risk yet to be defined. So we don't know exactly what these can do, and yet we don't know what the medical options we can offer for the patient. So, the technology is improving and research is ongoing, and we're still trying to find, and we will find something in the future. And as soon as we know, it's going to be categorized. I'm going to quickly talk about high-risk breast cancer genes. One of them is called P10 or Codin syndrome. It is rare. It is one of the high-risk, can cause breast cancer up to 50% in women who's been affected by this gene mutation. It can also cause endometrial, thyroid, colorectal, renal, and melanoma. Usually the person who has the Codin syndrome, they have a large head. That means like they have macrocephaly or difficulty in kind of fitting a hat. They will have also another clinical features such as benign tumor of hair follicles. It can cause benign overgrowth of tissues on the tongue, gums, and nose. It can cause rough patches on the palmar and plantar aspect. And also it can cause lipomas, penile pigmentation, and fibromas. Other gene considered high risk is called TP53 or Li-Fumani syndrome. Also, it increases the risk of breast cancer up to 60%. It can cause leukemia in the childhood, brain tumor, sarcoma, and adrenal cortical carcinoma. Other genes called STK11 or Pett-Jaguar syndrome. Also, it's very rare. Increased risk of breast cancer up to 50%, in addition to all of these cancers: colon, stomach, small intestine, pancreatic, uterine, ovarian, cervical, testicular, and lung cancer. And it has also a certain characteristic feature. It's associated with hamartomatous GI polyps, or usually they are benign, and usually they have mucocutaneous hyperpigmentation, usually at the lips, and the mouth, and the eyes, and genitalia. Other high-risk genes is called PALB2 or partner or localizer of BRCA2. It usually encodes the BRCA2 interacting protein and is the breast cancer susceptibility gene. It increases risk of female breast cancer, which vary whether you have a family history or not, and also increased risk of pancreatic cancer. CDH1, another high-risk gene that we find as well. It can increase risk breast cancer up to 52 and diffuse gastric cancer. One of the moderate risk genes, as we said, between 25 and 50 is under 50 is the risk of developing breast cancer is called CHEK2. The risk of female breast cancer is 37%, and the can increase risk of colon, kidney, thyroid, and prostate. Another moderate risk gene is called ATM. Beside the female breast cancer, it can cause pancreatic cancer. So if you remember, we said the high risk, we do surveillance and surgery as an actionable thing we can do for them, high risk gene. For the moderate genes, there's surveillance. People who carry this moderate risk genes, usually we do the mammogram and MRI every year starting at the age of 40. And those who have a gene that increases the risk of colon cancer, we advise them to do colonoscopy screening every 5 years, beginning at the age of 40, or 10 years earlier, the first degree relative affected with colorectal cancer. And pancreatic cancer as well, screening. So as for the evolution of genetic testing, as we said before 2013, we used to test only for one single gene based on the syndrome, and with time, improvement in gene coverage sensitivity. However, before 2013, there was one company that used to do this gene testing until in 2013, when the Supreme Court lifted the patent of that company, and other companies start doing more gene testing, and technology had improved, and then we start knowing these other genes, and we offer multi-gene panels. So what is the importance of knowing this? Why do I need to know? Really, why do I need to know if I carry a gene mutation? Some people, it can be nice to know the future. Some people don't want to know the future. So there's risk and benefits of everything. So the benefits of doing the test is that if you have a friend in your family that have cancer in your family, that has been going on multiple family members, that will give you a better understanding why this is happening. It will give you your future risk. It will give you your children risks as well in developing any cancer. Besides, most importantly, it will assist you with medical management decision. And that's where you can catch cancer very early and get a better outcome. And For the risk, a lot of people don't want to know because they will have increase in their anxiety level. That's kind of impact their psychological impact. If you have undergone the test and came back as normal test, that does not guarantee that you have a healthy gene. If you remember, with time, technology is improving, research is going on. So with time, we might find other genes. But for the time being, the genes that we know about, we test you for, came back normal. Again, it doesn't guarantee a healthy genes. And with implementing the multi-gene testing, we get more inconclusive results or variants of uncertain significance. So we're getting these variants of mutation, but we don't know what they do. Some people will say, I don't want to know that I have a variant. Just this is information, give me a lot of anxiety, and I don't want to know about it. So also very important, those who want to go for gene testing is to understand that there might be a possibility of insurance or employment discrimination. It's really that should not happen, since the Genetic Information Non-Discrimination Act, GINA, which is they came up with a federal law that creates a safeguard from genetic discrimination in employment and health insurance. So no one should ask you about your genetic test results, especially if you're going to apply for health insurance. There's an exclusion for this one, like if you're going for military or you're asking for TRICARE insurance, or if you want to apply for a long-term or disability insurance, that law does not apply, so they can know about it. And lastly is the direct-to-consumer genetic testing. So a lot of you have heard about 23andMe, Ancestry DNA, Family DNA, which is in 2008, the FDA had approved 23andMe to report 3 specific mutations that are commonly found in the Ashkenazi Jewish population. It is not a comprehensive testing for other genes associated with hereditary breast cancer. So the main reason for doing all of these tests is for recreational use, not for clinical purposes. And thank you very much, Wendy. You are with us today, and she's gonna help as well with the question and answers. She does offer a comprehensive multidisciplinary cancer risk assessment programs, counseling, testing, and assessment, and provide the patient with educational resources and psychological support, and help us a lot with medical management and with her beautiful group. And as well, the good thing is that she's available right now in telehealth. So people who don't want to go to across the LA, so she's available to talk to you, even if you don't want to go personally. This is definitely, you can go through these numbers again because the presentation is recorded. And I would love to give very special thanks to Janine Lynch, our oncology care coordinator. I'm sure that she's with us listening today, and she's the one who chose that topic. Thank you very much, Janine. And thank you very much, Michelle and Blake from marketing, who made all this possible. Special thanks to our amazing general surgery department, especially Dr. Catherine Giroux and Zachary Canus, who specializes in breast cancer surgeries. And lastly, it's very good to go to CVPH. So if you got late a little bit, you got your own excuses. Okay, thank you very much. Now.
Thank you, Dr. El Daouk. Thanks for sharing your expertise. We are now going to open it up for questions. We've already received a couple. Just a reminder that we've got genetic counselor Wendy McKinnon here on the Q&A as well. So I'm just going to also remind you that your Q&A button is at the bottom of the Zoom screen or in the comment field on Facebook Live. The first question is, I have been taking tamoxifen for 4 years. I understand that genetic testing of tumor can be done to determine if another 5 years of tamoxifen would be beneficial. Could you talk about this?
So,
go ahead.
No, you go ahead. You go ahead. I can, I mentioned a little bit about my presentation, but yeah, go ahead, please.
It's important to distinguish, there's different types of genetic testing. So what Dr. El Daouk is talking about is what we call germline genetic testing, where we're looking at your hereditary DNA through a blood test or a saliva test to look at a predisposing risk factor. There's also what's called somatic genetic testing or tumor-based testing, where we actually look at the tissue from the cancer and we can look at what genes have been changed or altered in the cancer, and that doesn't necessarily reflect something that's in your hereditary DNA. So the question about tamoxifen, I believe there are some genetic profiles. They can take your tumor tissue and look for certain genetic alterations in your tumor that might predict whether you are a good candidate to do long-term tamoxifen or shorter term. Again, this is something that, you know, an oncologist often talks about, or somebody like Dr. El Daouk, but it's important to remember the type of genetic testing we're talking about tonight is different than the tumor-based testing, which is more about therapy. But sometimes, you know, it is important to know that sometimes you can find a variant in a tumor that actually is an inherited mutation. And so sometimes that can translate into thinking about genetic counseling and testing to test specifically for that variant, but sort of two different types of tests. I hope, did I answer that okay?
I think so. Did Dr. El Daouk, did you have anything to add?
Just because from the research about BRCA 1 and 2 gene mutation, if you look at that, there was a little bit of kind of still research ongoing about the efficacy on taking tamoxifen or raloxifene, because there's a certain estrogen sensitivity based on the type of the BRCA mutation. So the most effective treatment in this situation, if you really want to go for prophylactic surgery, is the one that we can go with, specifically if they have BRCA 1 or 2.
Okay, thank you. The next question is, how effective are hormone modulators in high-risk women pre and post-menopausal? Are the figures good enough to avoid elective mastectomy in high-risk women?
So yes. Yeah, go ahead.
Right. So my thought about you know, the preventative surgery is that it really is such a personal decision, and I think that you know, chemo prevention, taking an anti-estrogen agent is just one of the ways that you can reduce risk, and surgery is another way. And I think it's just such an individual discussion with each individual in terms of what benefits and risks each of them. You know, taking a hormone agent may reduce the risk of breast cancer by as much as 50% in some studies. But again, you know, depending on what your genetic variant is, we know that most breast cancers that develop in somebody who has a BRCA1 variant may be estrogen negative. And so tamoxifen may not have as much of an effect. And so I think there's just so much that goes into that conversation, you know, whether you've had genetic testing, you know, how do you feel about surgery versus taking a medicine that may have side effects? And so I don't think it's an easy yes or no, do this or do that. I think it's a pretty complicated individual decision-making process.
Agree.
Okay, thank you. Our next question is, can you review what the risk of pancreatic cancer is for BRCA2 individuals?
So there is a difference between BRCA1 and BRCA2. And so the early data suggested it was really BRCA2, and the lifetime risks are somewhere in the 7 to 10% range. And for BRCA1, it's now emerging that the risk may be slightly higher than average, maybe in the 3% range versus about 1% for the general population. So we do see more pancreatic cancer in families with BRCA2. And in terms of screening, it's an important, so we typically, the way the guidelines are written is that families with BRCA mutations are not recommended to have any kind of pancreatic cancer screening unless they have a relative with pancreatic cancer, and in particular, a relative who has that BRCA mutation. And if there is a relative, we do have, so we have a GI person here at UVM Medical Center, Dr. Rick Zubarek, who is an expert in pancreatic screening and prevention. And so he is somebody that we consult with in cases where we feel like, screening might be something to think about. But we're still emerging on screening in terms of who's the best candidate and how effective is it. And so it really depends on the gene and the family history.
Okay, thank you. We have a request here to please explain again what you meant by gene testing for recreational use.
Okay, so as we said earlier, it is not a comprehensive test that tests for all the genes that can predispose to breast cancer. So it has a certain, it finds a certain thing in just to kind of, know your family and your genetics in your family, but it does not give you comprehensive testing where we can use it for clinical use and make clinical management guidelines.
And just to follow up with that, so the technology that's used with the direct-to-consumer testing is very different than the technology that's used for these genetic tests that are done through these what we call CLIA-approved labs. And so they're not actually looking at a gene, they're looking at what we call SNPs, which are called small nucleotide polymorphisms. So they're genetic changes that occur throughout our genome that researchers have accumulated information about the likelihood or association of a disease with certain of these polymorphisms. And so it's not a direct gene test, it's an association. And so, if there's concern about your family history, this test isn't necessarily going to tell you anything new or different than what you already know about your family history. So it's just a very different technology. It's not as accurate or as specific. And in terms of the BRCA testing that Dr. El Daouk was mentioning, the 3 mutations in BRCA 1 and 2 that are specifically linked with Ashkenazi Jewish ancestry are picked up through the 23andMe test, but that is not a comprehensive BRCA 1 or 2 test. So, if there's still concern about breast and ovarian cancer in a family, that is not a complete BRCA 1 or 2 test. It's only looking for 3 of thousands of mutations that have been identified in those 2 genes. So important to think about that they're 2 very different technologies.
Thank you for that clarification. We have a question regarding triple negative BRCA. What would cause this type of cancer?
So I'm assuming the question is referring to because it's not estrogen driven. So how do you get a triple negative breast cancer? And these are basic biology questions in terms of, certainly the BRCA gene is playing a role in DNA repair and how that all interacts with hormones or lack of hormones in terms of thinking about BRCA 1 and 2. I mean, that goes to very basic biology. And I don't know that I have a good answer about exactly how a triple negative cancer develops. Some people think that actually the estrogen receptors may be involved very early on and then they get lost. And so that, it's not that estrogen, it's a complicated basic biology question that I don't probably have a great answer. I don't know if Dr. El Daouk has a better.
Yeah, exactly. I was kind of, reading as well, like, they were saying why tamoxifen sometimes can help in these, research is still ongoing. It's not as effective because of maybe early on there was some estrogen receptors that got lost, as you said. So not sure what I'm going to tell you.
The gene is playing a large role here. Yeah. So the mutation. So, again, the idea that you're born with one copy that works normally and then one copy that has that mutation, and what causes that second, what we call that second hit to occur where then cancer can develop. We don't totally understand how that happens. But clearly it's the BRCA variant that is a driver in that type of cancer. But how that starts when that second hit happens, I think is still kind of a basic biology question.
Thank you. Another question, if you did the genetic testing and did not have the BRCA genes, does that mean you will not get breast cancer?
So I think, that if there's concern because of a family history, as Dr. El Daouk alluded to, there's many more genes now that we can test for, and there's probably 20 or 30 genes that we all carry, but have now variants or mutations in those genes have been linked to an increased risk of breast cancer. So we're now seeing a lot of people back in our clinic who had BRCA testing prior to 2013 and are coming back. And I think the studies suggest that about 10% of the early data where they looked at people who came back and got tested after a negative BRCA test, about 10% were showing to have a variant in another important gene. So, additional testing is available, but even negative genetic testing with all, the genes we can test for doesn't mean that somebody won't get breast cancer. You know, we all have that 10 to 12% baseline risk. And if you have family history, the risk may even be higher regardless of what genetics tells us. So it's important to remember that you still may be a candidate for screenings that are different from the general population because of your family history. So genetics doesn't always tell us the whole story.
Yeah, and remember, it's only 5 to 10% of all cases of breast cancer are due to genetics. So the rest can be sporadic, can be familiar, just clusters in your family is happening.
Thank you.
Then you have to go for screening.
Very important. Okay, we've got, how often is it recommended that we visit the genetic counselor in the years beyond initial diagnosis of the gene mutation? It seems like a lot of information has changed since my initial mutation diagnosis. Is there another professional we get that information from, or should I schedule with a genetic counselor?
That's a great question. And I think that's one of the challenges in our program is that, you know, once somebody gets that information and then is referred out to specialists to help manage their care, and then new information comes about and, you know, sometimes they have moved or, you know, there just isn't that contact. So absolutely, if somebody has questions, we try to encourage people when we see them is like, it's good to check in every 3 or 5 years, check back in and say, hey, what's new, what's changed? And we're always happy to see people back for follow-up. Absolutely.
Okay. All right. We have a couple of more here. If you have a breast marker, does it need more testing?
So if we find something on genetic testing, do we stop or do you do more tests? I guess I'm not exactly sure what the question means.
Like a gene mutation, find out?
Not sure. Perhaps they will ask a follow-up question with that.
Yeah.
And while they do that, or if they do that, we'll move to the next one, which is, how is genetic testing for breast cancer done? Does it hurt? Are there risks to the test? And is it covered by insurance? So we can take that one by one if you'd like. How is it done?
So usually it's done prior to COVID. It was in our clinic, we almost always did blood tests. So people would come in, we would counsel them. And if they wanted to get the test that day, they could walk across the hall and get their blood drawn. And it would be sent out to one of these laboratories. With COVID and with telemedicine and Zoom, we're almost doing solely saliva testing. And so we can send test kits after we counsel by telemedicine. We can send a test kit and sort of like some of these direct-to-consumer tests, you know, they can spit into a tube, it gets packaged up, you don't have to go to the hospital and expose yourself. And so we get good information from either of those samples.
And is that covered by insurance typically if it runs in the family?
Yeah, most insurance companies still have some criteria that you have to, so Dr. El Daouk sort of showed some of those, you know, these are the things in the family that you usually look for. And so insurance companies are often sort of looking for those. The costs of testing have come down pretty dramatically. And so there are situations where somebody's family is small, or maybe they don't have a lot of information about their family, or, you know, maybe they're not quite meeting those criteria. If you wanted to get one of these tests and it seemed after counseling like an appropriate thing to do, these tests can cost $250 out of pocket. So I think the cost, even if insurance doesn't pay, a lot of people now can afford to pay for these if they don't meet those criteria. And I know some of the labs have even looked at people who meet criteria and people who don't, and they're finding mutations, just as many mutations in both groups. So I think these guidelines, you know, we're learning that not everybody fits into that box who needs the test and could benefit from it. So that's part of the counseling process, is trying to tease some of that out. But yeah, I would say most insurance companies do pay, but it's actually pretty affordable if insurance doesn't pay.
Okay, great to know. Thank you. All right, we've got another saying, can you please provide, excuse me, the information again as to who we should contact to talk about whether genetic testing is recommended based on our individual family history.
So basically those who had a family history of breast, like the person who had a breast cancer younger than the age of 50, the person who had ovarian cancer in the family, prostate cancer at a young age, you know, that's where you should be kind of contacting. Anything to add, Wendy?
Yeah, I mean, I was sort of heard the question a little different, is like, so who do you talk to about getting the test? Is it your OBGYN or is it your primary care? That's sort of how I heard the question, but I think starting with your doctors is great. Some doctors are much more, like Dr. El Daouk is very familiar and an expert in this area. Not, you know, some doctors aren't as comfortable talking about this. So I think, you know, our program is always available as well. But I think starting with your doctor, talking about your family history and seeing, does it seem appropriate, and then reaching out to somebody who does have some expertise to go over those options for testing and what the implications would be.
Okay, thank you. Our next question is, if I have a genetic mutation and I have children, at what age should they be tested for the mutation?
So that, you know, it depends somewhat on what gene mutation has been identified, because the recommendations are somewhat different in terms of when you start screening. But it's in the genetics world, you know, we sort of have a mantra that, you know, testing, unless there's a medical intervention, it's probably not something, you know, it's not something that's really appropriate for a child to be tested for a BRCA variant. There's nothing you're going to do differently in childhood. And in fact, there's literature to suggest that might be psychologically burdensome information. So the youngest that you would start screening in somebody who has a BRCA mutation is 25, as was discussed in the talk. So that's often the age that we sort of recommend, is that at age 25, that's when it's going to be the difference between getting an MRI versus waiting till you're 40 to get a mammogram. And that's sort of the age where that screening changes. But we certainly see a lot of young women who are over 18, young adults who want to have that conversation and sort of decide whether they're ready to get that information or not. So you know, some of the other genes, the recommended screening is 30 or even 40. And so I think it depends a lot on one's, you know, what their life situation is, their maturity level, you know, what is it going to mean in terms of medical management? I think there's a lot of things that come into play in terms of when the right age is. I don't think there's a magic age to really to talk about that.
Okay, thank you. Looks like we've got a couple of more questions coming in. I'm just waiting for that. And we'll be wrapping up very shortly. Here is the penultimate one. Mom had breast cancer. Now I have had it. My sister has seen a genetic counselor who suggested I have genetic testing done before she has it done. Is that correct?
Yes. So again, going back to the idea that Dr. El Daouk was talking about, is that you're more likely to find one of these genetic variants in somebody who has the disease that you're testing for. So testing an affected relative makes more sense as a first test than testing the sister who doesn't have breast cancer. Because if the sister who has breast cancer has the mutation, a mutation in some gene, and her sister has a 50-50 chance based on they share 50% of their genes. So if you test the unaffected sister first and she's negative, you don't really know what that means, right? You don't really know what's the cause of breast cancer in the family. And you don't really, you know, this woman's risk is still going to be considered higher because she has a family history. So starting with somebody in the family who has breast cancer is absolutely going to give you the best information.
Okay, thank you. And now on to our last question. Perfectly timed. So if one discovers that they come from a breast cancer family, what is the next step? Which tests should be done immediately?
I would say the first step is to, you know, meet with somebody and, you know, go over the family history and go over the different options that might make sense. Who's the best person in the family? And, you know, talk about what is available, talk about the insurance implications, the screening and prevent, you know, so so I would say the first step would be to reach out to their provider and talk to them or get a referral to a program like ours and kind of get the ball rolling in terms of that piece.
Okay, I think that wraps it up perfectly on time. Thank you both for your expertise and thank you all for tuning in. Thanks again, Dr. El Daouk. Thanks again, Wendy McKinnon. On behalf of the University of Vermont Health Network, I'd like to thank you again for your interest and participation. We hope you'll join us for another class sometime soon. You can visit uvmhealth.org/healthsource for the other offerings, and we wish you all a great evening.